Hello, everybody. It's good to be with you today, bring you a new GYN Garage on this extra leap year day, which is also Rare Disease Day. My name's Ed Pavlik, and I'm in Lexington, Kentucky, where our weather is rather chilly in the mid-30s, but also sunny. My colleague is
Frank Lawton in London, where it is cold and wet and pretty miserable, actually. But anyway, it's warm where I am at the moment, so we're okay.
Great. Well, today we're going to consider a paper from Sweden that reports on the risk of ovarian cancer in women who have experienced pelvic inflammatory disease. This retrospective report was recently published in the American Journal of Obstetrics and Gynecology by a group of investigators in Sweden. Frank, what's your take on this paper?
Okay, it caught my eye for a number of reasons. Pelvic inflammatory disease or inflammatory disease and cancer diagnoses are not new things. Many of the people who might read this have probably forgotten that many years ago there were a couple of studies that suggested that the reason why 1A ovarian cancer cases were more likely to be right-sided than left-sided was because of subacute inflammation of the appendix. So this is not a new phenomenon. And indeed, the authors do say that out of, I think, possibly 10 or 11 papers, about half of them have suggested that there is a link between PID and subsequent epithelial ovarian cancer, and the other 5 say there isn't. So these authors have tried to determine whether there is an association between clinically verified pelvic inflammatory disease and epithelial ovarian cancer. I'll come back to the clinically verified bit because I think that's quite important. The numbers look good. They've looked at a large population, but they've selected, and I think quite rightly, from about 2015, where the Swedish Cancer Registry has registered high-grade serous ovarian carcinoma, probably the one with the worst prognosis. The interesting fact, I think, is that the age range for patients in Sweden developing or with a history of PID, the age at which the diagnosis was made, is between 40 and 46 and 16 to 79. 79 seems a very old age to develop pelvic inflammatory disease. And the lead time between the diagnosis of PID and the development of ovarian cancer in the risk group was 15.6 years. Now, I'm wondering whether this is actually chronic pelvic inflammatory disease rather than acute episodes. They do try and look at acute episodes, only 1, 2, 3, or greater than 4. And they do say that there is a dose response curve. The more episodes of PID that you have, the greater the risk of ovarian cancer. And I don't think anyone would argue with that. The problem I have is, how was the diagnosis of pelvic inflammatory disease made? Was this done on swabs? Was this done on laparoscopy? Was this done on pelvic ultrasound or clinical symptoms? And the reason I say that is that the ICD that they've used includes things, and I've never heard of oophoritis. I don't know what is pelvic disease that is only limited to one or both ovaries. Pelvic peritonitis is a completely different pathological condition from a bit of local salpingitis. They've tried to bundle them all together as pelvic inflammatory disease, and my concern is that because the definition is so poor and we don't actually have evidence that this is PID. I mean, for instance, chronic PID at laparoscopy looks like endometriosis. Certainly the scar tissue would look like endometriosis. So I'm not sure that the diagnosis is actually appropriate. Clearly, the longer you have whatever is called PID, the more likely you are, they say, of getting ovarian cancer. I can't see the link here. I don't think that they've really added at all to the knowledge of PID, whatever that is, inflammatory disease, and the risk of ovarian cancer. And if I were a patient with pelvic inflammatory disease and I went to see my doctor and I said, I've had PID, how does that increase my risk of ovarian cancer? I think your doctor would have to say, well, hardly at all, 1.2%, something like that. So it's not a risk factor that I think is going to be used in algorithms for the screening of ovarian cancer. And I'm not actually certain, to be honest, that this paper really improves our knowledge of the genesis of epithelial ovarian cancers.
Absolutely. I'm sort of right on the same page you are. The low frequency of the PID and the with ovarian cancer is the most striking thing. I think the nicest thing about this paper is the dose response curve, which I've put up right here out of their paper. It is noticeable that the range, the 95% confidence intervals shown on the graph, extend into the relative risk points, which are the symbols. And so, I don't, although these are reported to be as a trend here at the bottom to be significant, I'm not so sure if they really ring true in terms of significance. I think the other thing I'd like to add is that, and it's really what you've already said, is this a symptom that is unrelated to ovarian cancer for the longest time, and then it's joined by another cause of symptoms that are related to ovarian cancer, and this is not possible to determine by the way they've approached the problem. So the link may or may not be there. Although they've taken the multiple episodes of pelvic inflammatory disease, the time information is missing. I think you've pointed that out. And so, this leads me to believe that we just don't know enough to say that some course lasting so long is related to a future event called the appearance of ovarian cancer. The one thing that's sort of vexing in my mind is that clear cell carcinoma is called to our attention by the paper, but not much attention is paid to endometrioid ovarian cancer, which seems to behave differently. The relative risk for it is not as high in their paper as it is for serous and high grade. I think that this might have to do with the fact that maybe endometriosis leading to endometrioid ovarian cancers may have really been surgical cases, which are part of their exclusion criteria. And so maybe that relative risk that's reported for endometrial cancer is affected by or biased by the treatments for endometrial cancer. So they're really not included. Although they're included in the cohort, they actually are really not included in the cohort by that problem.
Yes, I think one of the problems is that they link endometritis, which almost by definition is a localized intrauterine or endometrial problem, with peritoneal inflammatory peritoneal disease, which is a more global problem. And I'm not sure that they can put in order to find lots of cases of PID, they've bunched together a load of, I think, disparate pelvic inflammatory conditions, and they've tried to link them all to the risk of developing ovarian cancer. And I don't think the data are strong enough to suggest that is the appropriate way forward. And we don't have any evidence about the causative agent. We don't know any things about the treatment. Is recurrent PID actually just associated with 4 new cases, or is it just an inflammatory reaction or a flare-up of previous PID? So there are lots of weaknesses in this study, and I don't actually think it adds anything more to what we already know.
I was struck too by maybe their cleverness that they had to take a 1999 to 2022 time span and adjust it for things that didn't occur until 2014, in terms of distinguishing high grade and low grade cirrus from each other in the registry, and then adding grade after 2014 is something in the registry, and then tumor stage was introduced in 2004. So they've probably done a heroic job in trying to get everything out, but it's what you really like is one box out of which you pull everything.
Yes, I think that's a very good point. They've mixed and matched everything, and there may be something there, but there aren't the numbers and that there aren't the data actually, as you say, to say that's the risk. Yeah, things won't change, I don't think, because of this study.
Okay, very good. Well, I look to doing this again with you again, Frank.
Okay, my friend.
You take care.